Hi, good afternoon. This is Janelle Gunn, and we'd like to welcome you all to our update for private sector organizations on the 2019 coronavirus disease response, or COVID-19. We're so grateful for all that you are doing to keep your employees and your communities safe, and we're pleased to have Dr. Jay Butler with us here today to give some updates from CDC and answer some questions. So thank you all to those who submitted questions in advance. We're going to do our best to get through them. And we really appreciate your engagement. So I'd like to introduce Dr. Jay Butler. He brings a lot of expertise to this. You've probably heard him from previous phone calls as well. He is the Deputy Director for Infectious Diseases. In this capacity, he provides leadership to the efforts of CDC's 3 infectious disease national centers and helps to advance the agency's cross-cutting infectious disease priorities. He brings lots of experience, over 30 years of experience, both in the field and in here at CDC, so has a lot of great perspectives. And I'll turn it over to him to provide an update on where we're at with the coronavirus.
Great. Thank you, Janelle. And good afternoon, everybody. Good morning to those of you out on the West Coast. Today's March 30th. So it's interesting to think it was December 31st that the world was first notified of the cluster of pneumonia cases that occurred in Wuhan, China. So just a reflection before we get started is we're here to talk about a pandemic caused by a virus and a disease that we didn't even know existed only 3 months ago. And it just is both humbling and fairly stunning to think how much the world can change in only 3 months. Of course, as of today, the virus has spread pretty much around the world. There's been laboratory-confirmed cases in over 200 countries now. There's almost certainly some bias in that, depending on where testing capacity is, but the virus has now been documented for several weeks on all of the inhabited continents of the Earth. The majority of cases right now are being reported in Europe, but also every jurisdiction in the Americas is involved now. The United States actually has the most laboratory-confirmed cases of any country, including more than were confirmed in China as well. Here in the United States, there have been over 140,000 confirmed cases, probably actually a little closer to 150,000 by now. Unfortunately, there have been over 2,400 deaths. Every state has seen cases, some more than others. There are certainly hot spots, New York City, the chief among them, but also seeing some fairly dramatic increase in the activity in the Boston area, New Orleans, and other areas around the country. And I recognize that depending on where you're at, it may look very different, but there's a whole slew of information that's available on the status of the epidemic at cdc.gov/COVID-19. And also that page is going to be getting a bit of remake later in the week. So we really want to be able to provide useful data in a graphically a way that graphically is presented to be able to facilitate communication. So please do keep an eye on that website. We continue to find that the people at highest risk of severe illness and fatal outcome are those who are older, particularly over age 70 to 80, and that people with underlying heart, lung, kidney disease are at higher risk, as are those with diabetes. There will be a descriptive paper coming out in the MMWR later this week highlighting some of the risk factors for more severe disease. Now, that said, I think there's a couple of paradoxes here that are always tricky in the communications. The vast majority of people who become infected with the SARS-CoV-2 virus will recover completely. In fact, we're learning more and more about the very mild manifestations in some people and also asymptomatic infection. However, younger people are not completely immune to more severe disease. We do occasionally learn of, unfortunately, people in their 30s and even 40s winding up in the ICU with COVID-19. Let me just walk through some of the emerging hot topics. One of the issues that I just touched on is what appears to be a more likely role of pre-symptomatic transmission and even asymptomatic transmission, where we have data from cohorts of people who have been exposed with testing. We're finding that it's not uncommon to have fairly high amounts of virus present in the nose and throat before onset of symptoms. And in fact, of people who develop symptoms, the highest amount of virus is at the time of the onset of symptoms with some decline afterwards. So this, it may be a bit of a game changer for us as we look forward in terms of trying to determine what are the best ways to mitigate transmission and to slow the spread of the virus. I think everyone is aware of the goal of flattening the curve. That's become a household term now. The overall goal there is to distribute the impact of the pandemic over as long a period as possible in order to maintain critical infrastructure and particularly to keep the healthcare system from becoming overwhelmed. So one of the issues that we are also looking at because of that is whether or not use of face covering might be of utility in the community to prevent transmission from people who are either not yet symptomatic or asymptomatic. We don't really know what role asymptomatic infection might play, but as we look at some of the experience around the world, in areas where face masks are oftentimes worn more often for the wearer's protection, there may actually be a benefit because of source control with this particular virus. So we're looking hard at the possibility of using face covering or non-medical masks as a method to basically, as an environmental control, if you will. Again, not something that necessarily protects the wearer, but something that would be an additional tool in the toolbox of community mitigation measures, in addition to what's been done already for social distancing. I imagine everyone is aware, speaking of social distancing, that the guidelines coming from the White House Task Force have been extended through the month of April. As we look around the country, I think there are 17 states now that have had some type of stay-at-home orders statewide, 49 states that have closed schools statewide. And the only state that hasn't closed schools, our understanding is 99% of the schools actually have closed based on decisions made at the local level. These community mitigation measures are part of what we do, an important part of what we do to flatten the curve until we know more about the status of any chemoprophylactic agents. Right now, there are basically none. There are therapeutic agents that are under study, and we certainly can talk more about that if you would like. A vaccine is probably at best 12 to 18 months down the road before that would be available for more widespread use. I was talking about face covering. It's important to recognize the importance of maintaining personal protective equipment for healthcare workers. There's been a lot of work done in the response that's now led out of FEMA and the National Response Coordination Center to be able to tap into the Strategic National Stockpile and also to be able to receive donations of PPE and other equipment such as surgical masks to be able to get them out into communities where they're needed by healthcare providers. Another real hotspot of concern is the long-term care facilities. As I was mentioning earlier, the persons at highest risk of severe illness are older persons and persons with chronic underlying conditions, and many people in long-term care facilities are both older and have underlying conditions. So some of the worst situations we've seen in terms of outbreaks have been in long-term care facilities. As of now, we're aware of over 400 long-term care facilities that have had cases in a large number of states. So it's an area where we're doing everything we can to provide technical assistance to our partners at the state and local level. Regarding testing using the PCR and other nucleic acid assays continues to become more available. There are now over 20 platforms that have emergency use authorization granted by the FDA. The number of test results that have come back are over 400,000 so far. There is a lot. The capacity in the commercial labs is greater than in the public health labs. So far, about a third of all the tests that have been completed have been in the public health labs. So I really want to acknowledge the important role that the commercial labs have played in terms of meeting the demand for testing. There are, in addition to more than just traditional PCR, I was mentioning nucleic acid assays. This is helping us to move toward being able to push testing as far out into the healthcare system as possible, and also get a faster turnaround on results. The latest EUA that was granted is for a nucleic acid assay that can be performed in many laboratories that are present in larger community centers, perhaps also in some of the larger multi-specialty clinics, and can return a result in as little as 15 minutes. Ultimately, the goal will be to have some sort of true point-of-care test that would be performed by a provider and have a result back before the patient leaves either the emergency department or the clinic. There is a lot of work that's occurring right now to move us in that direction. And of course, that is normally how influenza is usually diagnosed in this country. Also, much HIV and hepatitis C testing is performed that way also. We also have a lot of interest in serological testing. Here at CDC, we have an ELISA assay that's been developed. Serology is probably not going to be very useful in terms of diagnosing acute infections. It will be more useful for epidemiological assessments to answer some of the questions that we have about how often subclinical or asymptomatic infection occurs, and to be able to assess population-based immunity levels as the pandemic continues to spread. There's some interest in the commercial sector to be developing serological assays as well. I would have to defer to FDA to discuss any status of emergency use authorization applications. I know there has been some development of rapid serological tests that have been marketed in other countries. Question we often get is, are they any good? At this point, we don't have a lot of data or assessment on those. But it's a very pressing issue, we know, and we're very much involved in being able to evaluate the utility of serologic assays as well. So at this point in time, maybe this is a good chance for me to just stop talking and start going through some of the questions.
Okay, great. Thank you. I'd like to remind folks that this call is intended for partners in the private sector. So if you were media, we won't be answering media questions. And Media questions should be sent to media@cdc.gov.
A very clever web address.
So I have some questions here about like mail and incoming packages. Are they safe? Should businesses be doing anything particular with those?
Great, that's an excellent question. So people may be aware that there was a paper published by both CDC and NIH a couple of weeks ago, really looking at what are the maximal survival times for the SARS-CoV virus in the environment on various surfaces, at various temperatures, on different materials. And it's important to recognize that this paper really looked at maximizing the opportunity for the virus to survive. So it's an important paper, but also has to be interpreted in light of the real world situation. In that paper, it was possible to, under right conditions, to get virus that could be recovered from cardboard or paper. However, the epidemiology of COVID-19 doesn't really point to rapid dissemination of the virus through the mail. Given the amount of mail and various produced goods that come out of China, and particularly out of Hubei province, where Wuhan is located, if this were an important mode of transmission, I think we would have seen much earlier popping up of, if you will, metastatic foci of transmission around the world. Whereas what we saw during January and the first half of February was spread outside of China, primarily by way of travelers who had become infected in China and who had traveled while asymptomatic, but developed symptoms after return. And the cases that occurred secondary to those travelers were mostly among household contacts. So this points away from a really widespread transmission through contaminated goods that were sent around the world. Currently, the bulk of the evidence still points towards respiratory droplets as a primary mode of transmission. These droplets are generated, of course, during coughing and sneezing, but even as I sit here talking, I'm producing a small amount of respiratory droplets as well. And so this is of concern as we begin to learn more about the amount of virus that may be present in the nasopharynx prior to onset of symptoms. It also the other possible mode of transmission that I've touched on already is contamination of surfaces. And I think for at least a month now, everybody's become very familiar with the concepts of hand hygiene, knowing that hands are an important mode of transmission for a number of respiratory viruses, and we would expect it's likely for the SARS-CoV-2 virus as well. And then also decontamination of surfaces, particularly high-touch surfaces such as doorknobs or touch pads. I've noticed in a restaurant that now does takeout service, they have a whole jar of pens for people to sign their credit card notices. Then they move it over to the dirty pile, and then there's someone who goes through about once an hour or so and wipes down the pens with an alcohol wipe and moves them back to the clean side again. So these are some of the kind of things that are being done to be able to reduce the risk of transmission by fomites. Another question we oftentimes get is whether or not airborne transmission is occurring. And the difference between airborne and respiratory droplets is airborne is like what occurs with tuberculosis or the measles virus, that it's not just a matter of droplets that fly through the air until gravity takes over and they fall to the ground, but it actually becomes a airborne particle that's potentially infectious and can float around the room. It could even be entrained into the ventilation system and spread through that route. There is not a lot of evidence for that at this point in time. Again, always the caveat in all of this is we're talking about a virus and a disease that we did not know existed 3 months ago. But the emerging epidemiology still does not support a prominent role for airborne transmission. That said, we do recommend, particularly in healthcare environments, especially when there's a possibility of aerosol-producing procedures being performed, that airborne precautions be taken by healthcare workers.
So you noted earlier in your comments, and we have some questions about asymptomatic and pre-symptomatic, and if we know anything about when a person might be most infectious.
Yeah, that's a very good question. And it's one of the things that over the past couple of weeks, as we have more experience with this new disease, where the SARS-CoV virus may behave differently than the SARS coronavirus. In SARS, the peak level of virus and likely the peak level of infectivity is at the peak of illness several days after onset. For SARS-CoV, the highest amount of virus in the nasopharynx appears to be at symptom onset, and in those people that we have samples prior to symptom onset, the viral load can be fairly high. Exactly when does someone become infectious is not entirely clear, but I think it's entirely plausible that it could even be as early as a couple of days before onset. And this is fairly unusual for respiratory viruses. We know that flu sometimes it starts being shed a few hours before onset of symptoms, but this is particularly concerning with COVID-19, that there's possibly a period of days of infectiousness. The other difference between COVID-19 and influenza is the onset of COVID-19 can be fairly subtle. And in fact, for many people, the disease can be very subtle. I chatted with one gentleman in his 40s that had a documented infection. And he actually never had any cough at all. He felt a little off. The next day felt more off, had a little bit of a headache, some muscle ache, thought he might have had the flu, took his temperature, and he had a low-grade fever. And then he thought about some of the international travel that had involved Europe at that time, and became concerned that he might have COVID-19 and was tested here in the United States where he was at, and was found to be positive. He recovered after about 4 days and never really had cough or shortness of breath, a little bit of runny nose that he was unsure whether that was attributable to COVID-19 or not. So it's one of the challenges with control of this virus, and it actually is a challenge to some of our initial approach of test and isolate, to know that the virus may spread from people who are not yet necessarily symptomatic, and is the reason why community mitigation, social distancing, and some of these things that we've been instituting and that we've been talking about over the last 20 minutes may be so important.
So you mentioned in your comments some perhaps face coverings for either essential workforce, non-healthcare workers, or the general public, and seems like maybe some clarification on who that might be protecting. Can you comment on that?
Sure. And there actually has been some discussion for at least a week or two now about people who've been exposed, who are part of the critical infrastructure workforce, being able to monitor for symptoms but continue to work while wearing face cover. And that was more just because the symptom onset can be fairly subtle sometimes. With the newer data suggesting that there's the potential for transmission prior to symptom onset and possibly even from asymptomatic people, it does raise the question about what role face covering would play more broadly. One other observation is comparing the U.S. to the experience in South Korea, where, of course, there was some very aggressive test and isolate procedures, but there's also been widespread use of masks. And I think many of us have looked at the rates of infection that are confirmed in South Korea, particularly over the past week or so, with a great deal of envy because it did seem to plateau off very well. Many people were attributing that to test and isolate, which certainly did play a role. But it also raises the question about the frequency of mask use in communities in South Korea, which in some of the communities where there were high rates of disease were even mandatory. And so it does raise the question of whether or not face masks, even if whatever reason they were being worn, might have played a role in mitigating, basically in source control. So to summarize that, I think putting the list of observations together, it does really begin to raise the question of the utility of using masks as source control to be able to limit spread from people who are infectious, knowing that we may not be able to have good clinical markers for who's infectious. And I see this as an extension of something that we commonly do when someone is symptomatic, and even with COVID-19 has been recommended all along. If someone is coughing and sneezing and needs to be in public or going into the healthcare system, they should have a mask on to be able to limit the spread of those respiratory droplets. And that may very well be something that we need to be expanding to a broader swath of the community. I think there's some questions we're trying to sort through very quickly in terms of what are the thresholds to make that recommendation, when should it be worn, and what are the measures to decide when it's no longer needed.
Great, thank you. There's some questions both online and received in advance about close contact and how is that defined and what's prolonged and how is prolonged defined?
Yeah, so oftentimes and I feel like I've seen this concept of the 6 feet develop over the past 20 years, starting with SARS and maybe a little before that. And I'm sure many people on this call are aware that if you're in the EU, they'll say 2 meters. So it's not a magic number of 72 inches is not good and 73 is a problem. So it's getting back to that concept of how respiratory droplets are spread as they come out of the source person. They fall to the ground. And so the closer, the greater likelihood of exposure, the more time you spend in that close proximity, the greater likelihood there is of an infectious exposure. In terms of what's a minimum time, the data are such that it's a continuum. I think I would be hesitant to break it out too much, but in general, the way we've looked at it is comparing a quick passage of greetings being low risk, whereas sitting next to one another at a dinner would be of a moderate risk. So it really is a continuum of the variables of how close you are, whether or not the source person is coughing or sneezing, and then the amount of time together, as well as the susceptibility of the person who's exposed.
There's some questions in here. If you're a business that's open and maybe have an employee who's sick, what kind of things should you put into place? Yeah,
so the first thing that's perhaps the most important if someone's at work and becomes symptomatic is they should be isolated away from other employees and customers. This is one of the areas where we have recommended use of face covering in the community for quite some time now. It does not have to be a surgical mask or an N95. In fact, to preserve those, we would recommend against it. Again, you're basically just trying to cover the nose and the mouth to limit generation of respiratory droplets. You want to be able to get the employee either home to self-isolate or if they're ill to a place to be evaluated to determine whether or not hospital care is needed. In terms of other employees, notification within the appropriate parameters of respecting privacy is important. And I encourage everybody, particularly with larger corporations that have HR legal support, to review what are your corporate policies, as well as any state or local regulations that may apply in this situation. In terms of the environment, ideally, I think this is an area where the ground is shifting some as we continue to learn more about COVID-19. We do have some guidelines on the website about cleaning and being able to decontaminate areas. I think those will continue to be updated as we continue through the experience with the pandemic. I think with some of our newer learning, it raises the question about how much already people in any public area may be infected with COVID-19. I do know some of the practices that I've just observed is that a number of stores that remain open, such as grocery stores, which are critical to be able to maintain food supplies, many are cutting back on hours so that they can have more time invested in being able to do very thorough cleaning to keep the workspace as well as the customer areas as safe as possible.
So I'd like to build on a question. I feel like you've answered it in some ways, and you're talking before about mail and packaging and respiratory droplets, but I think it might benefit for folks to kind of hear this different view from it. So the question that we've gotten a few different ways and times is, can I catch it from food?
Yeah, that's a great question. So in the traditional sense of what is a foodborne pathogen, that appears to be very unlikely. So, catching it from food is probably going to be more in the situation where you're eating with somebody and there's respiratory droplets that fall on food as you're eating it. Right now, there's not evidence that there's contamination of food that then goes through the food distribution system. So I think that's it. The bottom line is it's not known to be a route of transmission for COVID-19. So it's certainly something to consider. But I think the basic rules for food safety, hot food's hot, cold food's cold, whatnot, still apply, obviously, because just because we're in the middle of a COVID-19 pandemic doesn't mean we're all protected from salmonella or norovirus or any of the more traditionally thought of foodborne pathogens.
As a dietitian, these are all music to my ears. Hot food's hot, cold food's cold. We have a series of questions that are sort of in the same spirit, like how do we know if the curve is flattening? When do we know if this pause is working or not, and when can we sort of wake up again? Yeah,
so those are great questions, and it seems like modelers are the new dinner guests that you want to have as soon as you can have dinner guests again. And they really do play a critical role. If we look just solely at case counts, and laboratory confirmed cases, it becomes very challenging because ideally we want to put the resources that are available in the spots where transmission is occurring or about to start occurring. When case counts are going up, it's important to recognize that alone as a measure is basically reflecting transmission that occurred 10 to even 14 days ago. So why do I say that? It's important to recognize this is, while this is an acute infection, it has an incubation period. The range is 2 to 14 days. Probably the peak is right around 5 days, 6 days. The onset can be subtle, so people may not seek care or testing until after 3 or 4 days into the illness. Although it looks like turnaround times are now on average down to about a day or two, particularly as that initial surge that hit the commercial labs is being addressed, it still adds up to a number of days. So this is where the modelers come into play and will be helpful not only in identifying what are the areas that are on the upsurge, but also when things begin to wind down again. So unfortunately, in many ways, this is different from influenza, where we know basically most all of the influenza viruses behave very similarly, and we would be more confident in that type of projections in an influenza pandemic. We're always learning new things about the SARS-CoV-2. So it will be a learning process as we go forward to determine the optimal ways to give the I'm not going to say the all safe because it's probably going to be more of a scale back of the interventions. For instance, when is it appropriate to reopen schools? When is it appropriate to loosen up and have more businesses open, particularly to be able to keep the economy going? I think it's very likely that for some time for businesses that allow teleworking and are able to maintain productivity, that is going to be something that will continue. And then finally, mass gatherings are important. Early in this pandemic, there appeared to be an important role of travel and mass gatherings. So that'll be ongoing work to determine when it's best to be able to adjust those recommendations as well.
Can you say anything about sort of the three things that are going on right now: allergies, some flu, and some coronavirus? Yeah.
So, that's a great chance to talk about some of the challenges just in terms of identifying when someone has COVID-19. I mean, particularly, I think many of us who are working long hours these days, we generally don't feel ourselves to begin with. But then add that into the pollen season, which we're definitely into down here in the South, as well as the fact that we still have influenza activity around the United States, makes it very hard to know, just based on symptoms of respiratory illness, whether or not it's COVID-19 or not. So this is one of the reasons why we have very keen interests in not only being able to increase the availability of diagnostic testing using some of the platforms that exist now, but also being able to support the availability of more rapid and more widely available testing. I know there's been talk about home testing. That's ongoing research as well. I think if those tests are validated, it can be a good way for people to know, have a little more guidance in terms of when to self-isolate and when it'll be critical to stay home from work. And maybe one last thought along those lines, and maybe hearkening back to the earlier question about, I'm going to reinterpret that question of when is this all over. As we look at influenza pandemics of the past, particularly 1918, it went on for about 2 years before it really tailed down, and then that H1N1 virus became the predominant flu strain circulating, causing seasonal flu until shortly after World War II in 1947, when there was a shift in the H1N1 type. So it will not be over in a few weeks, but what we hope we could be able to do is be able to loosen some of the community mitigation so that we can hit that sweet spot of doing the things that it takes to be able to save lives and to reduce transmission, but also not have the untoward effects of people not being able to have the appropriate care of their chronic conditions or their additional emerging health conditions, as well as the impact on the economy and our educational system. So it really is an ongoing process of balancing the costs and the benefits.
And then we have a series of questions about PPE, some sort of saying they might need some, or where can they be accessed. I'm wondering if you could just comment on that.
Yeah, so the availability of PPE is really being run now under the Associate the Assistant Secretary for Preparedness and Response, who has had responsibility for the Strategic National Stockpile since about mid-2018 now. And then that is part of the overall FEMA response as well. So those requests probably need to go through the State Emergency Response Coordinator and to direct them up to the people who are best suited to be able to respond and provide advice.
So we are just about at time. I'm wondering if there's any key messages or things you'd like to leave our private sector and business partners with.
Sure. First of all, thank you for your partnership. These are difficult times, and I know that's just not a statement from a healthcare provider and public health professional perspective, but for all of us. And the world will never be the same again as we continue to learn not only about what we have been learning over the past couple of decades about emergence of zoonotic diseases that adapt to infect humans and the potential for global spread of new viruses. We've also learned a lot more about the global supply chain and how during a pandemic response, it's much broader than just the health issues that are impacted. It also goes the other way. I think many of us in health are aware that economy has an important influence on the health of the population, are seeing that in ways that are very real and painful that we've never seen before. So I hope that out of all of this, we will learn that we are all in this together, and that through the relationships and the planning that involves both health and the private sector unrelated to healthcare will be more prepared for the next event like this that happens. And not to end on a really sour note, but we've seen influenza pandemics before. We will see them again. I would not be surprised if we don't see more events with pandemic disease caused by other viruses. This one seems to be a particularly bad one, so let's all stay in it together, because I think together we can address this, although, of course, standing together 6 feet apart. So thank you for the chance to talk with you. I hope everyone's well, so I wish you well.
Thank you, Dr. Butler, and thank you all for joining us today. This concludes our call. We will continue to update guidance as we continue working on this issue, and we will also continue having these types of calls. Your input and your questions, if not answered today, are informing our future works and understanding where there might be some gaps in our guidance. So thank you again, and have a great day.